ARDS kills roughly 40% of the patients it touches. Acute respiratory distress syndrome, ARDS, is one of the most challenging syndromes in all of critical care medicine. It is not a single disease. It is a heterogeneous clinical syndrome that can be triggered by pneumonia, sepsis, aspiration, trauma, pancreatitis, and dozens of other insults. And what they all have in common is a final pathway of diffuse alveolar damage, catastrophic lung inflammation, and severe refractory hypoxemia. And here is what makes it uniquely difficult. The ventilator that is keeping your patient alive can also be the thing that kills them, if you do not manage it correctly. Every tidal volume you deliver, every PEEP setting you choose, every positioning decision you make, directly determines whether that patient's lungs heal or whether they sustain ventilator-induced lung injury on top of the injury that already brought them to the ICU. Today, we build the complete ARDS framework, from recognition and diagnosis through the full 5 Ps of evidence-based management. Berlin definition, lung protective ventilation targets, prone positioning, neuromuscular blockade, PEEP optimization, pulmonary vasodilators, pharmacotherapy, and extracorporeal membrane oxygenation. This is everything you need to manage ARDS at the bedside. Let's get into it. ARDS is defined by 4 criteria. Master these, because recognition is the first step to management. 1. Acute onset. Symptoms must develop within 1 week of a known clinical insult or new or worsening respiratory symptoms. ARDS is not a chronic condition. If the timeline is longer, reconsider the diagnosis. 2. Bilateral infiltrates on chest imaging. Bilateral opacities on chest X-ray or CT not fully explained by effusions, collapse, or nodules. The pattern does not need to be symmetric. It needs to be bilateral. 3. Respiratory failure not fully explained by cardiac failure or fluid overload. Cardiogenic pulmonary edema must be excluded, clinically, echocardiographically, or with objective measurement if doubt remains. 4. Hypoxemia severity defines the category. The 2012 Berlin definition uses the PaO2 to FiO2 ratio on a minimum PEEP of 5 centimeters of water. Mild ARDS, PF ratio 200 to 300. Moderate, 100 to 200. Severe, below 100. The lower the PF ratio, the higher the mortality risk, and the more aggressive the intervention. What has changed recently? The 2024 New Global Definition, a major update, expanded ARDS to include patients on high-flow nasal cannula at 30 liters per minute or more using SpO2 to FiO2 ratio of 315 or below. This matters clinically. It enables earlier diagnosis in resource-limited settings and in patients managed without intubation. Estimates suggest this expansion increases ARDS diagnosis rates by 15 to 25% globally. Earlier diagnosis means earlier intervention, and earlier intervention saves lungs. One of the most important clinical advances in ARDS research over the last several years is the recognition that ARDS is not one disease. It is a heterogeneous syndrome with distinct biological phenotypes that respond differently to the same treatments. 2 phenotypes have been consistently identified. The hyperinflammatory phenotype, characterized by high levels of inflammatory biomarkers, IL-6, IL-8, TNF-alpha, and protein C. These patients have more severe shock, more metabolic acidosis, and higher short-term mortality. Critically, research has shown that the hyperinflammatory phenotype may actually benefit from higher PEEP strategies, while the hypoinflammatory phenotype may be harmed by them. This is why the one-size-fits-all approach to ARDS management is being challenged. The hypoinflammatory phenotype. Lower biomarker levels, milder shock, relatively better oxygenation despite meeting ARDS criteria, lower short-term mortality but still significant. These patients may tolerate lower PEEP and respond better to conservative fluid strategies. We cannot routinely phenotype at the bedside today the way research protocols can. But understanding that these phenotypes exist and that the patient in front of you may respond differently to the same intervention that worked on the last patient is essential for clinical judgment and for interpreting conflicting trial results. Lung protective ventilation is the cornerstone of ARDS management. The landmark ARDS NET trial in 2000 demonstrated that ventilating with 6 milliliters per kilogram predicted body weight, rather than 12 milliliters per kilogram, reduced 28-day mortality by 22%. That single finding changed ARDS management permanently. Here are the current targets, based on the 2023 ESICM guidelines and the 2025 German guideline update. Tidal volume. Target 6 milliliters per kilogram predicted body weight. Range of 4 to 8 milliliters per kilogram is acceptable, but 6 is the target. Note, this is predicted body weight based on height and sex, not actual body weight. An obese patient does not get more tidal volume because they weigh more. Plateau pressure, at or below 30 centimeters of water, measured on an inspiratory hold, reflects the distending pressure applied to the alveoli. Above 30, barotrauma risk and VILI escalates significantly. Driving pressure, at or below 15 centimeters of water. Plateau pressure minus total PEEP. The 2025 research literature confirms driving pressure as the strongest independent predictor of mortality in ARDS, and a 2025 review in Respiratory Physiology and Neurobiology argues convincingly that driving pressure is a more physiologically relevant target than tidal volume alone, particularly in obese patients where chest wall compliance is reduced and plateau pressure overestimates true lung stress. Mechanical power, below 17 joules per minute. Mechanical power integrates tidal volume, driving pressure, respiratory rate, and PEEP into a single comprehensive marker of ventilator-induced lung injury risk. It is increasingly tracked in clinical practice as an emerging VILI target. Permissive hypercapnia. pH at or above 7.20 is acceptable. When the tidal volume required to normalize CO2 would exceed safe pressure and volume limits, accept the higher CO2. The hypercapnia is the price of lung protection, and it is a price worth paying. The 5 Ps framework provides a structured, evidence-based approach to ensure that every major ARDS intervention is systematically considered for every patient. The first P, prone positioning. Proning is one of the most powerful interventions in severe ARDS. The landmark PROSEVA trial demonstrated a 28-day mortality reduction from 32.8% to 16.0% in patients with severe ARDS, a nearly 50% relative risk reduction when prone positioning was applied early and for at least 16 consecutive hours per session. The 2023 ESICM guidelines and the 2025 German guideline both strongly recommend prone positioning for at least 16 hours per session in patients with severe ARDS, defined as PaO2 to FiO2 ratio below 150 on FiO2 0.6 or higher. Proning improves dorsal lung recruitment, reduces ventral overdistension, homogenizes regional stress distribution, and reduces driving pressure. If your patient has severe ARDS and is not being proned, that is an evidence gap at the bedside that needs to close. The second P, paralysis. Neuromuscular blockade eliminates patient ventilator dysynchrony, reduces respiratory muscle oxygen consumption, and, critically, prevents PSILI, patient self-inflicted lung injury, which we discussed in depth in the dysynchrony video. The 2025 German guideline recommends neuromuscular blockade for the first 48 hours in severe ARDS. The Accurasis trial showed mortality benefit, though the larger ROSE trial did not replicate this when light sedation was used in the control group. Current practice. Consider NMB early in severe ARDS, particularly when dyssynchrony is refractory to sedation optimization and when driving pressures remain elevated despite optimal settings. The third P, PEEP. PEEP in ARDS serves to recruit collapsed alveoli, maintain end expiratory lung volume, and improve oxygenation. But it is a two-edged intervention. Too little PEEP leaves alveoli collapsed at end expiration and allows cyclic atelectrauma. Too much PEEP overdistends already open alveoli and worsens driving pressure. The optimal PEEP strategy remains one of the most actively debated topics in ARDS management. Fixed PEEP to FiO2 tables from the ARDS NET protocol provide a starting point. Individualized titration, using esophageal pressure monitoring, electrical impedance tomography, or pressure volume loop analysis, is increasingly supported by the 2023 ESICM guidelines as a more physiologically sound approach. Routine high-pressure recruitment maneuvers are no longer recommended. The ART trial showed increased mortality with a sustained inflation approach. Individualized, lower-pressure recruitment may be applied cautiously on a case-by-case basis. The fourth P, perfusion. In ARDS, hypoxemia drives pulmonary vasoconstriction, increasing right ventricular afterload. Severe ARDS can cause acute cor pulmonale, right heart failure from pulmonary hypertension, which worsens oxygenation and cardiac output in a vicious cycle. Inhaled nitric oxide and inhaled prostacyclins are pulmonary vasodilators that reduce pulmonary vascular resistance selectively, improving ventilation perfusion matching and oxygenation without systemic hypotension. These are rescue therapies. They do not improve mortality, but they can buy time and improve oxygenation while the underlying cause of ARDS is being treated. They are also used as a bridge to extracorporeal membrane oxygenation in refractory cases. The fifth P, pharmacotherapy. Corticosteroids have been the most studied pharmacological intervention in ARDS. The evidence suggests that early administration of corticosteroids, methylprednisolone, in the exudative phase of ARDS can reduce ventilator days and improve oxygenation. The 2023 ESICM guidelines give a conditional recommendation for their use. Fluid management is the other key pharmacological decision. Conservative fluid strategies after initial resuscitation reduce ventilator days and ICU length of stay, as demonstrated in the FACT trial, without increasing renal failure or shock. Once the patient is resuscitated and hemodynamically stable, dry is better than wet in ARDS, veno-venous ECMO, extracorporeal membrane oxygenation, is the ultimate rescue therapy for ARDS when even lung protective ventilation cannot maintain acceptable gas exchange without inflicting further injury. The indication is refractory hypoxemia, PaO2 to FiO2 below 80 millimeters of mercury, despite optimal conventional therapy, including prone positioning, neuromuscular blockade, and optimized PEEP. Extracorporeal membrane oxygenation allows the ventilator to rest the lung, applying ultraprotective settings, sometimes as low as 3 milliliters per kilogram PBW, while the extracorporeal circuit handles gas exchange. The Eolia trial did not show a statistically significant mortality benefit for early extracorporeal membrane oxygenation versus conventional management, but a subsequent Bayesian reanalysis and meta-analysis suggested a clinically meaningful benefit in centers with ECMO expertise. Extracorporeal membrane oxygenation for severe ARDS is a high-complexity, resource-intensive intervention. The decision requires specialist involvement, careful patient selection, and should be made early in the disease course before irreversible organ failure supervenes. Let's bring it all together. ARDS is a heterogeneous syndrome. The 2024 global definition now includes patients on HFNC, enabling earlier diagnosis. Know the 4 Berlin criteria. 2 phenotypes, hyperinflammatory and hypoinflammatory, respond differently to the same interventions. Clinical judgment matters more than protocol when phenotype is uncertain. Lung protective ventilation, 6 milliliters per kilogram PBW, Pplat at or below 30, driving pressure at or below 15. These are not targets, they are ceilings. Accept permissive hypercapnia to protect the lung. The 5 Ps: positioning, paralysis, PEEP, perfusion, pharmacotherapy provide the systematic framework. Prone positioning for severe ARDS, 16+ hours per session, early, consistently. The Prosiva survival benefit is one of the strongest in critical care medicine. PEEP, individualize. Avoid high-pressure recruitment maneuvers. Use driving pressure as your guide. Pulmonary vasodilators are rescue therapies. Corticosteroids and conservative fluids are your pharmacological anchors. And extracorporeal membrane oxygenation for the lung that cannot be protected any other way. In the next video, we go into special populations: pregnancy, obesity, COPD, neuromuscular disease, and post-cardiac surgery, and how each one fundamentally changes your ventilator management strategy. Subscribe so you do not miss it. Thanks for watching Just Breathe RT. I will see you in the next one.